Monitoring coagulation or understanding coagulation has never been easy. We all grew up understanding coagulation as intrinsic and extrinsic, and that has been imbibed into our memory. But in the last decade or so, the whole concept has seen new light. Now we are thinking of coagulation apart from the intrinsic and extrinsic pathways, which are still relevant in the course of platelet adhesion, initiation of a thrombus, amplification of the thrombus at a site, and propagation to the rest of the body, thereby causing micro and macroembolism, which continues to be a nuisance in intensive care management and therapy. With this new understanding, the methods of monitoring have also changed in the last 2 decades. Whereas the old tests continue to stay as main course of our monitoring, the other 3 factors, which is basically bleeding, clotting, and the new one, which is getting more and more focused now, fibrinolysis, has also become an integral part of evaluation and monitoring. To achieve this, we have changed certain ways, but not all ways have been changed, and new techniques are coming in which we need to understand. Now, I don't know what routine monitoring of coagulation in ICU is, and I don't know whether any guidelines exist. I stand educated if anyone can tell me. Then we have to monitor the coagulopathy statuses that arise out of various disease syndromes coming in ICU. Then post-surgical critical care forms a very integral part of bread and butter critical care. And more anticoagulants and coagulopathies are intervening with onset of transplant surgery, advanced cardiac surgery, neurovascular surgery, etc. Then on the other hand, we are interfering with coagulation in therapeutic modalities. First one is we are using a lot of procoagulants to correct coagulopathies. Then there are patients on anticoagulants and ever-expanding field of antiplatelet agents. And then DVT prophylaxis has become a unacceptable lapse if you don't do it in intensive care. Then antithrombotic treatments have come in. Coronary artery disease has thrown a huge spectrum of management of antiplatelet and anticoagulant management, including extracorporeal devices, which are expanding as days go away. As recently as in last 2 years, ECMO has entered India. Along with it, coagulation monitoring has become a mandatory one. Then we are using antifibrinolytics, and add to all these complications, the mainstay of antisepsis treatments like activated protein C are basically anticoagulants, and we are still floundering in dark how to monitor the anticoagulant aspect of antisepsis agents. Traditionally, we have always depended upon last 50-60 years on laboratory-based coagulation tests. We call them now non-viscoelastic tests, which we'll explain in a moment later. But what are the issues with these basic lab-based coagulation tests? There are sampling to result delay, which are a problem with every one of us in our intensive care units. We send a sample and waits for hours together while patient is actually bleeding or clotting or both. Then, what we are doing are plasma values rather than whole blood. There is no adequate information on the platelet function, and then they are performed at standard room temperature in a room distantly away from the intensive care unit by someone whose knowledge in intensive care management is near to zero. These techniques have their advantages as well. The first advantage, which I have not put here, is they are cheap. They are economic to the patient. They are standardized in the labs, done by expert technicians, supervised by hematologists probably. But what you get is a number, not the function in the patient. And then there is no data, and fibrinolysis, which we realize is an ongoing process in every critically sick patient. The whole blood test, there is no sample preparation needed at your end. Microaggregation and whole blood analysis is done. It's easy to do. But again, commercial kits are not available at the bedside. Then there are some purified platelet tests which depend on microaggregation or macroaggregation. They need to be done by expert technicians, and no commercial kit available. It is done on normal blood sample. Then platelet function analyzers are there. They give you a precise effect, but they are only at research level and they are not being used in day-to-day management of critically sick patients. First of all, platelet quantification and qualification of the platelets has become very essential. The last 2 speakers spent enough time telling you what are the problems with therapeutic intervention of platelet pathologies. Then what we are doing today is an automatic cell counters, and every time the platelet count is up or down, you lift the phone and start getting hysterical about why your platelet count is 12,000 when it was yesterday 120,000. Then comes back the manual count saying that, oops, I'm sorry. So this has been further negotiated through laser technology and automated technology, but still we don't have a bright light at the end of this dark tunnel. Then platelet function tests, most of them are static tests. There are some dynamic tests, which is bleeding time is the basic dynamic test. Then there are lots of platelet response stimulation tests in the lab. All of them, mind you, are done in the lab. Ultragra, clot signature analysis, platelet function analyzer, platelet works, platelet aggregometry. None of them are done in any one of the hospitals I have worked or I am working in. I don't know whether any one of you are using these platelet tests. They remain textbookish. None of them has given us clear solution what to do when your platelets are actually falling. You don't know whether the number is adequate, whether the function is adequate or not. So still we are left in dark. Then there are few traditional tests. All of us as clinicians, our teachers have taught when we were medical students, and we still depend upon them. First one of them is thrombin time. This is the time taken for conversion of fibrinogen to fibrin. This is basically a technetium point of care test is also available bedside, but is not validated. The normal is for whole blood is 39 to 53 seconds, and for secreted bloods is 43 to 63 seconds. This specifically measures the activity of thrombin, so it's very sensitive to heparin. This excludes both intrinsic and extrinsic pathways in the whole system. It's elevated mainly in the heparin presence. Most people, especially the cardiology departments and post-cardiac surgery and post-cardiology stenting and interventional departments are using it as a standard method, lab standard method for thrombolysis, and they got certain trigger points to see where their thrombolysis are effective or they're pushing the patient into bleeding status. Then probably the commonest used test is APTT along with PT. This APTT is basically an activated test, and it tests both intrinsic and final coagulation pathway. It is activated, called activated because it's activated with coagulase, with cavalin, and it's called partial because the thromboplastin which is added excludes tissue factor and includes only phospholipid, that's why it's partial. Prolonged even with low dose of heparin. The most important is this prolonged APTT is seen in the deficiencies of several factors and the presence of either artificial or natural kallikreins, which we do every day is 28 to 32 seconds depending upon your lab standards. The next one is PT, which everybody knows. Probably all of us do it every day or every alternate day on our patients. This takes basically extrinsic and common coagulation pathways. This is elevated famously in warfarin therapy, which many of our patients are on, and rest of the difference of vitamin factors, etc., etc. Normal values are 12 by 14, but these values vary from department to department, hospital to hospital, country to country. To equalize this, international normalizing ratio has been developed with an international standard so that we can compare between the values of two institutions when patients travel from one institution to another institution, or if we are doing any research. INR target ranges are specified by patient population. Each patient population is a different one, and we maintain different INRs in different patients. I'm not going to go into that because that's not the topic of my lecture anyway. Then, are there any point of care monitors, or do we have to continue to send our samples to the lab? There are point of care monitors even before the viscoelastic coagulation monitors have come into market. There are several companies are producing this, especially for patients who are on warfarin at home, but none of them have been standardly correlated in a statistical way to say that, just like your glucose monitors, to say that these monitors can be probably trusted upon, at least in the circumstances that work in hospitals. These are the ones. There is coagulocheck by Roche, Hemopron by ITC. There is SIBA Corning monitor, which is very famously used in US, I'm told. There is good correlation for this SIBA Corning monitor in particular studies. It has been used in transfusion algorithms more than in coagulopathies of intensive care. Now, the other thing that we need to monitor, we are facing a lack of technology here across the world, is fibrinolysis. We all know a lot about fibrinolysis these days. We intensivists are very worried about this. And in my field, where we do a lot of liver work, we are always on the lookout whether patient is going into either primary or secondary fibrinolysis. Clot lysis time, which some people do, is a direct measurement. And you can do the end product measurement, which is FDP and D-dimers, which I trust most of us do. This, then you can add to whole of this to fibrinogen concentration, which is depleted in fibrinolysis. Several methods are there to measure the fibrinogen concentration, and some of them are POCs, but they are not available in India. Then you are using heparin and low molecular heparins very actively in all your units, depending on the indications. The heparin monitoring has to be monitored. Heparin treatment has to be monitored very closely, and this is done best in cardiothoracic field. They have been using ACT for a long time. Heparin concentration can also be measured in various Indian labs, but it's not standardized, and there are technological problems in measuring this. Then lab APTT happens to be the next strong indicator to monitor the heparin activity. Then there is something called high dose chromatin, which I have not any experience with, done by Hemocron company. Low molecular heparin monitoring is an enigma. None of us have any clue to seen various preparations, and then antithrombin activity is more important in kinetic studies. That takes us to viscoelastic point of care coagulation monitoring. Now the advantages are bedside advantages. It can be done on bedside, and basically it tells us the in vitro in vivo difference. The whole thing is that here we are not actually taking the blood to a lab and measuring various indicators or numbers in this. What we are doing here is basically putting I'll spend a minute on this particular slide. There are three viscoelastic POC devices available in the market in the world. The most common of them available in India is thromboelastography. The second one, which is making entry into India's rotation thromboelastogram, is called ROTEM. The third one, which is not available in India, educate me if any one of you got it in your institutions, is sonoclot. This has become very famous in East Asia, especially in Japan and Korea, where a lot of liver work is being done on almost an industrial proportion. Now let us look at the basic principle of the so-called viscoelastic POC point of care devices. What we do is we take a small cup, this is called a cuvette. Into one we put a miniature amount of blood, something less than 0.5 ml, and either we rotate the cup or we rotate the pin in the cup. This is done by the bedside within seconds of taking blood out, so it is done at room temperature. And the clotting process which starts in the cup is akin to the clotting process that is going to happen in the patient who is in ICU or in the operation theater. Once the blood starts clotting, it becomes viscous. That's why it's called viscoelastic. It develops elastic properties and it has its elastic reflections on the pin. The movement of the pin either impeded or slowed by the viscoelastic properties of the blood, and this reflects on the electromechanical or optical transducer and conducted to a data processor. These data processes in all the three devices generate a signal. This signal is a real-time, at room temperature, bedside reflection of the clotting process. This goes from there onwards. There is a diversion between sonoclot and the other two parameters like CHEG and the ROTEM. This one is basically sonoclot. I won't spend much time because it's not being done in India. And interestingly, most of the studies and most of the indices that is developed in this sonoclot are done with epertonin. And epertonin is banned by FDA now, so it is of no use to me or to anyone in India. I'll go back a bit with your permission. Now, these two fall into the same category, whereas sonoclot falls into the other category. Now the optical image that is given by sonoclot is called sonoclot signature. There is strong correlation of ACT of sonoclot with lab ACT. So this ACT is taken by many centers to be true ACT. We'll go away to the other one, where CHEG and ROTEM are the two analyzers that are being used widely in Asia, Europe and America now. And CHEG is the commonest in India, with which I had some experience in the last 1.5 decades. This now generates a signal. When you put the blood here in the cuvette and start rotating the cuvette, it takes a bit of time before it starts clotting. That is equal to clotting time or R value. Then when the clot starts forming, the signal is transduced into a curve. This curve starts at a particular angle, which is called alpha angle. You will see the relevance. There is a bit of time before it becomes flat, which is called K value, and then the clot starts forming as the clot strength increases and reaches a point where the amplitude is maximum. It is called at the strongest point of the clot is called MA. It stays flat for a few minutes and then starts resolving. This is fibrinolysis or clot lysis time. So in this component, we are measuring all the particular values that come in various lab values that we discussed in the last 10 minutes. Now there are several viscoelastic properties that come out. Please concentrate only on the tag. There is a native value where no activator or inhibitor has been added. there is a caveolin added to neutralize certain values, and then heparin is added if patient has been already heparinized. And platelet mapping is done if ADP and arachidonic acid are added to the cuvette. Now I don't want you to get confused here. I won't tell you any values. It comes by bedside and there's an indicator card correlating each value with a particular pathology or therapeutic interventions. Clotting time, clot kinetics, clot strengthening, amplitude, and lysis, which is fibrinolysis, are given as various values in TEG and ROTEM, and these values correlate to whatever intervention you have done or whatever pathology patient is suffering from. Now, this TEG ROTEM POC coagulation monitoring has been used in post-cardiac surgery, hepatology in a very wide way, hypercoagulability, and recently a lot of trauma protocols are being developed using TEG and ROTEM as well. Ultimately, we are using it in obstetrics in our own center. Yeah, thank you. I'll go very fast now. These are the standard TEG images. This is a normal TEG. This is hypercoagulable, not resolving at all. This is hyperfibrinolytic. Fibrinolysis is taking place very quickly, and this is hypocoagulable trace. Now, I can go on like this. There are so many studies here. Each therapeutic intervention can be monitored: heparin therapy, low molecular therapy, direct thrombin inhibitors. This is an interesting one where factor 70, the Novo 7 administration, has actually strengthened the clot. This is a real-time value. You can really see without going into any numbers, even for the naked eye, how the therapeutic intervention has acted. Antiplatelet therapy is being monitored. Ultimately, where do we stand? This is my last slide. Time-honored tests are still routine and cheap and accessible if the patient is not very critical. High-precision specialist centers units are shifting to point-of-care devices, which are basically viscoelastic. Viscoelastic devices have made their entry and are here to stay. We better understand them. They give us an opportunity of virtual in vivo real-time monitoring of coagulopathy and intervention. Standardization, education, and training are strongly needed. Many centers are doing both now. There is good scope for critical care students and practitioners for research in the future. All of us, including myself, we need further orientation and problem-solving workshops with these new devices which are standardized to main lab values that we have been doing for the last 2 decades. Thank you.